My name is Director Brackett. I'm a family nurse practitioner at the Cornell Scott Hill Health Center. I've been meeting with Tony a few times recently, talking about your project that you guys are doing in the community, which is fantastic, and wanting to talk with you today about ways that you can connect people to services, tell you a little bit more about the services that we have, so that we can, if you find someone out there that needs help, that needs treatment for their blood pressure or other resources, you can certainly send them our way. We found actually a survey, only about 20% of people, at least 2 years ago, were accessing our website. So not that many people have access to computers, or they're not using the internet for their health care. But just so you know, the Hill Health Center is the first community health center in the state of Connecticut. It's still the largest community health center in Connecticut. It was established in 1968. So it's been around a long time. We now have 3 satellite clinics in addition to the main site, which is on Columbus Avenue. And let me just show you on here some of the resources. Let's see about us. So our fact sheet we currently have available on the website. You can download. I brought a couple of copies, but I didn't bother. Our fact sheet lists our board of directors, which is over, as a federally qualified health center, we have over 50% of our board of directors are patients at the health center. So the health center is actually governed by some patients. But you can see here, just to show you some of the numbers, we have for 2009, 32,000 patients. So it's quite a large number of people. And of those, 2,900 are homeless patients. And just to give you a sense of what the breakdown is, with some of our major chronic diseases that are being followed, and the demographics, and the patient payer sources. This is really important for you to understand. We have a lot of misconceptions, I think, in the community that it's a free clinic. It's not a free clinic, but we do actually provide free care or somewhat subsidized care to about 23% of patients. They do have to come in and establish a sliding fee scale. It's not that you just walk in like there is, I know, in other free care programs around town. But patients can be put on a sliding fee scale. We have an eligibility specialist from DSS who's on site Monday through Friday who can see if people are eligible for services. We have a homeless program, which I'll talk more about. And we also have a full-service pharmacy. So patients who don't have insurance or in the process of applying for entitlements can get put on a temporary, like 1-month program to get free medications. At our pharmacy, we also have programs with major drug companies like Pfizer and AstraZeneca, so they can get direct access to their free care programs. So if someone needs, these are brand name meds like Toprol, which is metoprolol, Norvasc, Lipitor, like all the big ones, they can actually get for $3 for a 3-month supply. So there are a lot of resources. When you hear someone say, "Oh, I haven't taken my blood pressure medicine," their blood pressure side, they haven't taken their medicine. There's really, besides just their own personal barriers, there are not that many barriers. Once they actually get into care, they should be able to get on their medicine on a regular basis. We have a pharmacy fund, which is subsidizing a lot of even those co-pays, those $3 co-pays, so people can get their medicines for free. Okay, but we have over 40% are Medicaid patients, and then we have our sliding fee scale, like I said, about 1/4, and then less than 10% which are private. But we do accept all insurances. So we have patients who have no insurance, and then they get insurance, they lose insurance, they get insurance, back and forth. They can still come no matter what. I mean, we accept anyone. We never actually turn anyone away. In addition to the medical services, we have a very large behavioral health department, which also includes South Central Rehab Center, which is the detox. It's really the only detox in town, a CRC, which is on Cedar Street. We have day programs like Grant Street Partnership, and then we also have outpatient behavioral health services, counseling, and other substance abuse services. We currently have a methadone program and buprenorphine. Okay, so our main site is on Columbus Avenue. Does anyone know where that is, 428 Columbus Avenue? So it's not far. I mean, it's between El Grasso and Church Street, so you know where the Yale School of Nursing is? You just kind of keep going down Columbus, that way you would get to that clinic. So that is our main clinic where we have behavioral health, we have a pharmacy, we've got pediatrics, OBGYN, and internal medicine. We have a clinic on Dixwell Avenue, which might be closer for a lot of the patients or people that you're seeing in the community to some of the sites. And that is at 226 Dixwell Avenue. It's right after, have you seen the school that has all the faces painted on the side? If you go down Dixwell, it's right around there, so it's not far. And all of those services are also accessible from there. So if you're finding, we also have a clinic in West Haven on Main Street and out in Derby, or in Sonia actually, right next to the Griffin Hospital. So once patients or people come, so if you're seeing someone and they don't have, you know, maybe they might actually already be connected to services, they're just not getting services, but you see someone in the community, you do a blood pressure screening, you find that they have high blood pressure, you're probably having a conversation, do you have a healthcare provider, do you have anywhere that you go? A lot of people, you know, as you know, with high blood pressure don't actually think of it as a problem because it's the silent killer, they don't have any symptoms, right? So until they have really high blood pressure, they're having headaches, they're having complications, they may not seek treatment. So it's really important to emphasize that they can come in anytime. We have hours Monday, Tuesday, and Thursday evening clinics, so we're actually open until 8 o'clock, as well as Saturday mornings from 8:30 to 12:30. People can walk in, make an appointment, or they can sometimes walk in and be seen in our convenient care clinic, which is like an urgent care walk-in clinic. It's a little bit, we're trying to work on getting more access. We've been talking about this issue. We actually have we have a nurse practitioner and a physician's assistant who go out to some of the soup kitchens and go to Columbus House twice a week. They have clinic hours, and we're hoping to open up some slots that we could say, okay, you know, we could streamline in. So you say you call in and you see someone, they really need to be seen that week. You know, maybe we can give them an actual time. Okay, come in on Wednesday between 10 and 12 and you can see Janina or you can see Bryce. So that's something we're working on our end, trying to figure out how to be a little bit more accessible, because right now, if you walk in the door and try to schedule an appointment, unfortunately, there's a 3-month waiting list for a regular appointment because there's such a demand for visits out there. So in terms of specialty services you may not be aware of, we have the pharmacy. We also have on-site a full-service ophthalmology clinic, which is actually staffed by Yale medical students and Yale fellows. We have podiatry, we have ophthalmology, podiatry, ear, nose, and throat, gastroenterology, cardiology, neurology. So we've established all of these specialty services because we've had such access problems at both Yale and St. Raphael's hospitals, trying to get patients with no insurance or with Medicaid into getting care. So this has really been helpful, and this has just happened actually in the last 2 to 3 years for the most part, besides ophthalmology. That's about 5 years now. So we've got access to a lot of really great services. Part of what I do, I'm the Director of Health Promotion, in addition to seeing patients as a nurse practitioner. So I oversee the nutrition and smoking cessation programs and other health promotion programs. So we can also get people in for counseling, for their diet, for weight loss, for diabetes. We have diabetes groups. There are a lot of resources that once you kind of get in, that patients have access to. So I don't know if you want to just do questions or how we should, you know, but we'd love to partner with you guys. I know you've been already going out into the community. A few of you came to our event on Wednesday at the library, which we appreciate. You know, we do a lot of outreach ourselves right now. Just to let you know, we have people every week at Community Soup Kitchen on Broadway, at St. Thomas More, at Columbus House, like I said, and Downtown Evening Soup Kitchen. We also have 2 homeless case managers, which I want to give you their phone numbers. If you're having someone who or if you see them repeatedly and they just are not getting anywhere, so you have someone's phone number you can actually give them to get in, you know, or you can just call while they're there with you. Also brought some of my cards, although I'm not the person that can schedule, the homeless case managers could probably help a little bit more. Let me just give you those now. So we have Doris Cherry, and her phone number is, so what questions do you have, or what have you been finding, those of you that have actually been out doing this already, when you're seeing people?
So should we tell them to come back every week, or?
Well, it depends. I mean, if they have, Well, for someone to be diagnosed with high blood pressure, it's 3 or more, right? You have to have had an elevated blood pressure 3 times. So, I mean, if someone has high blood pressure, and you mean to come see you for screening, or to come?
To go back to screen their pressure.
Well, if their blood pressure is high and they're not on medication, then you really, they need to get referred to get onto medication. Once they're on medicine, depending on how high, I mean, there's guidelines for if it's, hypertensive emergency, they need to be seen within a week to get their blood pressure checked again. But someone, a healthy person who doesn't have high blood pressure, it's really, once a year depending on risk factors. It's not a regular thing. What we find is that people go on and off their medicine, they forget to take it, or they're taking a half of it because they can't afford to get more, or things, those kind of barriers. So in that case, certainly, I think just making sure people are aware of what they can do. And I did bring some educational materials that you can hand out, or you can, talk with, you can just use it as a teaching tool when you're with someone, why we worry about high blood pressure, things you can do in terms of diet and lifestyle. Unfortunately, people who are eating in the soup kitchens, the diets, although they've gotten better, because there've been a lot of, there's kind of better collaboration with local, people, fresh produce and so forth, they're still pretty they're pretty high. I mean, if someone's controlled on blood pressure medication, typically we'd see them every 3 months, but if they're not controlled, that's really where we need to see them more often.
So I have a question. Oh, go ahead.
If we come across someone who does seem to have hypertension and have high blood pressure, do you think there's like a specific way to sort of like break it to them? I mean, we're not health practitioners. Is there a way to convey to them like, oh, your blood pressure is like high? Like, is there something specific you should say?
Well, I mean, you can find out that, if they're smoking. I mean, if they're clearly someone, also if there's someone who's actively using alcohol, I mean, that's going to raise their blood pressure. So you kind of have to choose your battles, I'd say. I mean, if someone's intoxicated when you're seeing them, you may want to direct them up to other resources besides treating their blood pressure first. But it is challenging, that's for sure. I mean, I think that saying, long term, this could do damage to your heart, to your kidneys, to your eyes. I mean, there are a few men in the room, but we often also, the risk of impotence for a lot of men tends to get them, if nothing else, if you just, because people don't worry, especially if you're homeless and you're out on the street, you're not really worried about long-term complications. So how it's going to affect them in the short term is really what you have to think about. But certainly showing them what it's doing to their body, you can use this as a reference. It's got some nice pictures. And I think also, like, making sure people focus on things, there's a nice thing here with what you can change and what you can't change. Unfortunately, there's a lot of things that run in families that you can't really do anything about, but knowing that your lifestyle, your salt intake, alcohol, tobacco use, exercise, being overweight, all these things can make a big difference for treating high blood pressure. So, I think it does get back down to basic needs, so knowing, okay, you can access care, you have high blood pressure, there's a place you can go, you can get your medicine, you have to take that initiative.
Right, so we often try to ask folks to come and check. So oftentimes we find patients with pre-hypertension or borderline hypertension cases. So what should we do about these patients?
Well, again, counseling them, it's hard, not being a healthcare provider, again, just saying, we're here to give you this information, you should have this checked again. These are things you can do in terms of your lifestyle, not smoking, drinking, eating well, not eating extra salt, exercising, these are not things that we're probably too concerned about. But, counseling that the risk as they get older is definitely higher, and then depending on what other diseases or problems they have, if they have high blood pressure, there's different goals for the, if they have diabetes, there's a different goal for the blood pressure. If they have a family history, a lot of people, if they do have a family history for a disease, just knowing at what age someone else had a heart attack, if they're getting closer to that age, sometimes that's something that can help them to feel like it's more of an urgency for them.
And what do we do about
you know, the problem, I mean, the problem we have by having opened up these community care clinics is that then people use them just as that and they never establish a primary care provider. Because the goal is really that, you know, they come in and then they establish a primary care provider that they see regularly, and then they get everything else done that they need to have done, all their other routine health maintenance needs, and getting their colonoscopies and their stress tests and whatever else they need to get done. Ends up being used kind of like a revolving door, like the emergency room. We want to avoid that. It's better than them not getting care at all, but we want to try to avoid overutilization of the convenient care.